Okay. Should start. Yeah. Okay, welcome everyone. My name is Susan Kavanaugh, and welcome to our presentation on Why Am I Dizzy? We have a wonderful group of specialists to talk to you tonight to explore the mystery of dizziness. And as each one is presenting, I will give you a little bit more information about them. But tonight we have with us Dr. Beth Moore in our internal medicine department, Dr. Michael Lerner, otolaryngologist, or ENT as we tend to call them, Arielle Feiman, our audiologist, and Marisha Koala and myself are both physical therapists, or what we specialize in vestibular therapy. So I just wanted to welcome you all and give you the idea of a format for tonight. We're each gonna, I will introduce each speaker, and we do have a Q&A at the end. We're happy to take your questions and answer them and bring up some nice discussion for you. Okay, so we got the idea for this presentation came about from all of you, our patients who came to us. You went from one practitioner to another, trying to figure out, why am I dizzy? So hopefully we can help you answer that question, give you an idea of the things that you can go through to kind of maybe make the trip a little shorter for you, so you don't have to go to 10 different people to find out the answers you're looking for. So let's talk about dizziness. I want you to know dizziness is one of the most prevalent complaints for which people seek medical help. An estimated 90 million Americans, older than 16 years old, or roughly 42% of our population, will complain of dizziness at least once in their lifetime. That comes from the National Institutes of Health. It is the third most common symptom amongst all our outpatients, and the #1 reason for adults 65 and older to visit their physicians. Next slide. Patients with dizziness will experience a significant decreased quality of life that can have a significant consequence for an individual. 33% report that it will affect their professional activities. 14% have changed or abandoned their profession. And many conditions can lead to symptoms of dizziness. It is estimated, though, that as many as 45% of the cases are due to vestibular disorders, but we'll get into more detail about that. Although common, it is one of the most ill-defined and misunderstood complaints in medicine. So I'm sure there's many of you out there that are complaining or have complained of dizziness at one point in your life. So our goal, like I said, is hopefully to unravel the mystery a little bit for you behind dizziness. And you can see by the slide, there are many, many reasons why you might end up dizzy. Many causes, and it's up to us as your healthcare practitioners to try and sort it out for you. It's probably dizziness is a symptom, and it's probably one of the few symptoms that has so many diverse causes. So our doctors are going to help us figure this out and discuss it in more detail. So we recommend, so if you should wake up in the morning and you're feeling dizzy, what do? Well, the first thing you do, if it's a serious dizziness, you're frightened, you don't know what's going on, get yourself to the emergency room. But if it's not a severe case and you're just concerned about what's going on, your first point of contact would be your primary care physician. To help sort this out, we asked our doctors on the panel to give us a brief overview of what they would see in a patient that came to their office complaining of dizziness, and what would they look for. So our first up is Dr. Beth Moore. She is currently a physician at our Long Ridge Medical Center with the Northeast Medical Group. Dr. Moore earned her doctorate in medicine from the Albert Einstein College of Medicine of, forgive me for the pronunciation, Yeshiva University, sorry. She completed her internship and residency in internal medicine at New York Presbyterian Hospital, Weill Cornell Medical Center. So welcome, Dr. Moore. And like I said, we presented her with the question, with the idea, okay, if somebody comes to your office, what do you look for? What do you do? And we're going to connect her up in a second.
So thanks Thanks for asking me to be here today, Susan, and everyone. It's a pleasure, and I'm honored to be a part of the panel. I was talking to a patient recently, and she had come up with this exact problem and was asking, why am I dizzy? So the first thing we always think about is, do we have a severe problem, and what is the nature of the secondary issues with dizziness? So I'm just going to run through a case study as if we were meeting a patient that had this problem. And the case that I'm going to talk about is a 74-year-old woman. She has a past medical history of some neck pain and arthritis at this portion of the body. She had some acid reflux, has something called ocular migraines, which often means she has a visual disturbance without a headache, and has sleep apnea, for which she receives no treatment. She had a venous malformation and a retinal problem in her eye that has resolved, but she follows up with her eye doctor. And she did have an incidence of vestibular neuronitis, which is commonly referred to as a vertigo type problem, several years ago, that was treated appropriately and resolved with physical therapy. The one thing she stated about her dizziness at this time is that it is quite different from the episode she experienced previously. She's generally a very well person. In November of last year, she had episodic chest pain, and had been evaluated with some workup. So the first thing we ask a patient is, what is your symptom? What is dizziness to you? Because dizziness can have a variety of presentations. Sometimes patients feel a spinning sensation. Oftentimes that's a vertigo. Sometimes they say they are lightheaded or that the room is moving. This patient simply said she was lightheaded, but it specifically occurred when she changed position from a sit or a squat to standing up. The feeling was specifically inside her head. It was not rotational. There was no spinning, and it did not happen when she rolled over in bed. She specifically noted that it started a couple of months ago when she was visiting her daughter in Colorado. She was at altitude at that time. But it persisted when she took another trip to California, and it is worse now when she has a new puppy that she's bending over with a lot. So there were some important negatives to her story. She did not complain of chest pain or racing heartbeats with her situation. That would be one thing we would consider a red flag. And she did not report any falls or any loss of consciousness. Again, findings that we would consider to be very concerning and worth looking at more urgently. She had no weakness or numbness in a limb or in her face. She had no slurred speech, no changes in vision or hearing, and she was not short of breath. So those are the kinds of important things that we might consider to be something that makes you want to go to the emergency room or see someone very urgently. Just to review: chest pain, falls or loss of consciousness, weakness or numbness in a limb or in your face, slurred speech or changes in vision or hearing. In this patient, she felt unsteady. It did not occur with driving. And so she was in the office and we tested her blood pressure. Sometimes the things we look for are a loss of volume in the blood. And that can be measured often through blood pressure testing. For our patient this time, her blood pressure had a slight difference when she was in two different positions, but it was not exactly to criteria, which we have certain measurements that we set for it being significant. She was tested to see if she was anemic or had a sign of blood loss, and there was none. She was normal. And because she had this recent discussion with chest pain, she'd also had a full workup for chest pain recently. So she had an echo stress test, which was both normal for her exercise and her heart was normal. She had had a recent evaluation for blood clots. So she had had a variety of blood tests, which were all normal. She had some scoliosis and had an x-ray that was done, which was also normal. The only thing she had had recently was a mildly positive D-dimer test, which is a non-specific test that's not helpful at this point. She had a breathing test, that was normal. And so I ordered a few things. I ordered a CT scan of her head and a CT angiogram because she had some problems with movement. And she had had this issue of having a blood clot in her eye in the past. Those tests, thankfully, both came back completely normal. There was no finding in the brain like a mass or an issue that's very worrisome. And she did not have any base of brain vascular problems that can lead to dizziness. Since common things happen commonly, I decided this is a patient who had some dizziness and had had vertigo before. So I sent her to our physical therapists to see what they could do for her. And what did they find? Well, they found that she was not having that problem. And that is not what her story sounded like. She didn't sound like she was having spinning or vertigo. And so in my office, I could not elicit that finding on exam, and I probably should have trusted myself, but I decided to try to give it a go and see if the physical therapist could come up with a reason, and they agreed with me it was not that problem. So at this point, she was sent also to Dr. Lerner. She had an interim problem with her, an unrelated GYN problem that led to a surgery. So she's not yet seen Dr. Lerner. But she returned to my office still complaining of worsening dizziness. And at that time, she was a little more orthostatic, meaning her blood pressure changed more when she changed position. And the other things you do with a patient like this is you do a very thorough neurologic exam to make sure all of the nerves that come out of the brain in the head and the neck are behaving normally. Sometimes there can be very specific findings that help us with dizziness. In this patient, her exam was otherwise normal. The only thing that was really abnormal with her exam was when she walked, she would walk straight with no problem, but when she pivoted or turned to go back the other way, she'd reach out for the wall and kind of totter a little bit. So now we're left with, what do we do for a patient who has problems like this and we can't find a reason? Well, I think 40% of dizziness will turn out to be something like vertigo that can be treated with an issue like physical therapy. Out of patients that are left, perhaps 50% of them might have a reason that's something along the lines of anxiety or problems that will be multifactorial. In an older patient, we make sure their medicines are not causing the dizziness. We make sure that bleeding or dehydration are not causing the dizziness. We might reduce blood pressure medicines if it is safe to do so, to make sure that they are not being over-treated for high blood pressure. Sometimes when a patient's in the doctor's office, their blood pressure is quite high, but at home or in a more restful situation, it is lower. If we give them too much blood pressure medicine, they can sometimes be overcorrected. And then we look for other reasons that can cause the change in blood pressure. Those things are often things like Parkinsonism can cause this, an abnormal blood protein level can cause it, or a cardiology evaluation has to be done. So the things that are left for my patient include, she's going to be sent for some heart testing to make sure she does not have an abnormal heart rhythm, that her heart doesn't go too quickly or cause a problem that's giving her dizziness, or too slowly. And she will also, she's eliminated a couple of supplements, herbal supplements that she started. That so far has not helped. And she'll follow up with Dr. Lerner, who she has not yet met with because of the other surgery. I think the final thing that I'll do with her is I'm going to look at her neck spine where she does have a problem with arthritis and make sure that there's no finding there that's putting pressure against the actual spinal cord. Sometimes we can have a patient who gets dizziness based on those kinds of findings. We'll continue to evaluate her from there. But she was an interesting case of somebody that with all the things we looked at, we could not yet find a reason, and we'll have to keep looking. She was very resistant to having an MRI, which is a higher quality study than a CT scan. So I've told her that we're really going to come to a point where we'll have to do an MRI because we can sometimes get more meaningful information from that than we've received so far. So I apologize for the talking on and on. My PowerPoint failed me today, but I hope that you've been able to follow the story of this patient that's had a number of tests and has so far shown us mostly normal findings, which is probably good, but she continues to have the problem.
Okay, thank you, Dr. Moore. Thank you very much. I think you can see the challenge of a primary care physician to try and sort out exactly where is this dizziness coming from, the different avenues you have to explore. So Dr. Moore did a nice job of showing us the many different things that she looked at. And to be continued, we want to know the end of the story. We'll have to check in with Dr. Lerner later to see after he evaluates her. So I stress the importance of having a conversation with your physician and letting them sort through what needs to be tested and guide you to the appropriate specialist that you need to see, whether it be a neurologist, a cardiologist, an endocrinologist, or a otolaryngologist or an ENT. That's why we say ENT. So I will bring in Dr. Lerner, because if it ends up being, as Dr. Moore has referred to Dr. Lerner for his opinion on whether or not this is an inner ear problem. Is it a peripheral vertigo problem, as we call it? But Dr. Michael Lerner is a laryngologist at the Yale School of Medicine and serves as director of the Voice Center at Greenwich Hospital. He received his medical degree from Tufts University, completed his residency in otolaryngology, head and neck surgery at Yale, and his fellowship in laryngology and neurolaryngology at the New York Center for Voice and Swallowing Disorders. Dr. Lerner, it's all yours.
Great. So thank you for that introduction. I'm also honored to be on the panel this evening, and I enjoyed Dr. Moore's vignette. I think it really does capture sometimes how dizzying it can be for the physicians and teams to try to figure out, what's going on. So what I wanted to share with you is the ENT perspective. I have had patients who've told me I've seen an ENT before, but I've never seen an otolaryngologist before. So this is just a kind of a fancy way to say ear, nose, and throat physician. So I wanted to start with, even though I take care of ears, and it's sort of a pun, but I wanted to, emphasize the importance of listening. So Sir William Osler is one of the fathers of modern medicine, and he said, listen to your patient. He or she is telling you the diagnosis. And so that's especially true, I think, with dizziness. What does it mean? And Dr. Moore alluded to this. I mean, when a patient tells me I'm dizzy, I then proceed to ask, well, what do you mean by that? And then most patients then respond, well, I feel dizzy. And so that kind of after that, we have this long conversation to really understand what an individual means when he or she feels dizzy, because it can mean a whole lot of different things. So it could mean that someone feels unsteady on their feet, lightheaded. Someone might feel dizzy when they say that when they have motion sickness, or when someone has nausea. Vertigo is something very specific that that symptom is when someone has a sensation of movement, either of him or herself or their surroundings. And so that's when people describe feeling like they're spinning or the room is spinning. People can mean swaying, or I've had patients describe that they feel like they're floating inside of their own head, all sorts of symptoms. And I think it's important to emphasize dizziness is a symptom, meaning it's a described sensation, but it's not at all a diagnosis. So that's our job, is to try to figure out what is the cause of that specific sensation. which is a very disconcerting sensation. I mean, most patients who suffer from dizziness that I speak with, it's the sense of total loss of control of your environment. And I've had patients tell me they would take pain any day over the sensation of dizziness. So when a patient is referred to an otolaryngologist or an ear, nose, and throat doctor for dizziness, really the question from my point of view is this dizziness related to the inner ear? So this is an external ear, but when we say the inner ear, let me just put a pointer up here. So patients sometimes, and a lot of patients I think read about this and understand that this like dizziness can be related to the inner ear. So they, might ask me, well, do you mean like inside my ear canal? Is that my inner ear? Or, even behind the eardrum, is this space here? Is that my inner ear? And that's not the inner ear, that's the middle ear. This is the external canal. The inner ear is this really weird looking structure behind all of that. And it kind of looks like a snail, but really this is the cochlea. That's the snail looking structure. That's for hearing. And then the balance organ of the inner ear are these are semicircular canals. And Dr. Moore alluded to these cranial nerves, these nerves that exit the skull base from the base of the brain. And so this is the 8th cranial nerve, has different branches. One goes to the balance organ. This is the vestibular branch of that nerve, and then the cochlear branch here. So that makes up cranial nerve number 8. So there's a 3D kind of structure. This is what a strange structure we have. 2 of these in each of our heads. So when patients, try to understand what does that mean, I think recently the best way I can think to explain it is this is like your internal accelerometer. So we all kind of use our smartphones now. So it's, how does the phone know what's up and down, and it is able to figure that out? And it's because it has sensors that can detect orientation in space. So, our inner ear structures, those semicircular canals on either side of the head allow us to detect rotation and acceleration. So specifically, the sensors that we have in these semicircular canals here allow us to detect linear and angular acceleration. And the importance of this is that it allows us to stabilize our vision or our gaze. So if we didn't have these accelerometers in our head, essentially, when you would be walking down the street, as your head is bobbing up and down, the whole world would seem to be moving. So, the reflex that this, system, really enables is called the VOR, or Vestibulo Ocular Reflex. And to break that down, it means this inner ear eye reflex. So it allows us to maintain and stabilize our gaze. And if it's not working, of course, you'll have this sensation of movement or motion when it's actually absent. So this illustration is just meant, in a way, you're seeing the eyes here, and basically this reflex is kind of correcting for motion, making sure your gaze, your vision is aligned. So so that's the question that I'm asking when I'm seeing a patient for dizziness. And so is this an inner ear type of dizziness? So as I started off with this slide deck, is the history. And when we say a history, a medical history means it's really having a conversation with the patient where I'm asking a lot of questions and followed by a physical exam. So in terms of the history, every medical student learns to ask all of these qualifying questions about any complaint or any symptom, really. So we're asking about, when did it start? In terms of dizziness, for some of the inner ear issues specifically, I'm wondering if it happened after, a head trauma, an upper respiratory infection. Those are kind of some inciting events for certain types of dizziness. But the big ones for me to understand the diagnosis really have to do with duration. How long are the episodes of dizziness, and some of the other factors about it. So if someone suffers from, and we're talking about, dizziness, which we already mentioned can mean a lot of different things, but if it lasts for a matter of seconds, the differential, which means the list of the possible diagnoses is not terribly long, but one of the most common ones, and a lot of people, I think patients are aware of this term, is, benign paroxysmal positional vertigo, or Bppv. And that's a type of vertigo or a spinning sensation when people have a sudden change in head position, usually in either a certain direction, sometimes in bed or when they bend down. And vasovagal reactions are basically like almost fainting, and that's the one where if you get up very quickly out of bed and you feel lightheaded. If the dizziness is lasting for minutes to hours, then we start to think about other things. For example, vestibular migraine, and this is not the typical, migraine headache, but it has a similar mechanism in a way. But this is vertigo that tends to be triggered by complex visual stimuli. So this is someone who develops a vertigo with, really bright fluorescent lights or flashing lights, or sometimes people who wear progressive lenses suffer from vestibular migraine, and it doesn't present like a typical migraine, so it's not, people don't all immediately recognize it as that. And Dr. Moore mentioned neurologic. Certainly there's circulation. The brain has to deliver oxygen to certain areas that are responsible for our balance systems, which certainly extends beyond the inner ear. So we have to think about that always. And then if the dizziness lasts for hours, and specifically if it's a vertigo type dizziness, we start to think about things like another diagnosis that people hear about, Meniere's disease. So Meniere's disease is essentially a problem where there is increased pressure, fluid pressure inside that inner ear structure that I showed you earlier. And with Meniere's disease, patients tend to have a combination of symptoms. So these patients will have vertigo that lasts usually for a matter of hours, but also these patients often experience tinnitus, or kind of a perception of sound when they're having the episodes. And also these patients experience fluctuating hearing loss. So it's a very, I think this term Meniere's disease is somewhat, understood in the lay public, but it really has to involve all of these different symptoms to really make that type of diagnosis. And unfortunately, there are patients who suffer from, dizziness that lasts for days. And then we start to think about, some of these other more global neurologic disorders. And even it can last for weeks to months. And imagine that existence. This is very uncomfortable and unpleasant to live this way. But this also causes us to think about even, additional disorders that I won't go into in terrible detail right now. So, once we've taken, that part of the history, we're looking for other clues. In a simple way. Is this your inner ear or not? So, I'm asking about other ear symptoms. So hearing changes, hearing loss, tinnitus, I mentioned that in the context of Meniere. So, do you hear, are you perceiving sound that's not there? In the case of Meniere's disease, it's classically this kind of roaring sound in one ear during the episodes. Sometimes patients describe feeling fullness or pressure in their ears. And then just asking about other ear symptoms like ear pain, drainage, which can indicate an infection in the ear, and then whether the patient has a history of ear problems in the past, like frequent ear infections as a child or prior ear surgeries. So, took the full history, then comes the physical examination, and yes, the cranial nerve exam is really important. And these are those, if the hearing and balance nerve is cranial nerve number 8, well, there are several other cranial nerves that are neighboring structures and really important to assess in the office. Patients will, have a full head and neck exam, including the ear. And then for patients with dizziness, I have to perform an extended balance examination, which checks, several components of balance. And I think we kind of touched upon this already, but it's not just the inner ear. It's a lot of systems that have to communicate with one another to help us basically understand our position in space. So one of the exam findings we look for is that we look for the presence of nystagmus. So this is involuntary beating of the eyes. The cerebellum is a part of the central nervous system and helps coordinate a lot of this information. So we'll do finger to nose testing, and this looks like a sobriety test, but that is exactly what that test is meant to assess. The Romberg test is really based on the principle that 3 major systems are involved for us to understand our position in space. So we need to have proprioception, so our joints need to be able to sense from the floor where we are. Our visual input, looking around at our environment, tells us where we are, and then the vestibular or inner ear system. So in the Romberg test, patients are standing and we have them remove the visual input. We have them close their eyes. And so if we remove one of the three legs of that table, so to speak, most patients should be able to still stand and be compensated. But if there's an issue with proprioception, their kind of joint sensation or the inner ear, they tend to maybe fall or have an instability. A head thrust exam, not uncomfortable, but I do warn the patients. I move the head back and forth pretty quickly, and I kind of joke with them that I'm not a chiropractor and there's no cracking involved, but I'll turn the head and have the patient keep their eyes fixed on used to say my nose, but now I say at the center of my mask, and I move their heads kind of somewhat without warning to one side or the other. And if those internal accelerometers are not working, if one side isn't working very well, the inner ear, then they might have difficulty, maintaining gaze, or they might kind of lose track of my nose and then have a delay before they're able to maintain that. So it's sort of like if you were to turn your phone and it's not rotating, besides checking that it's not in orientation lock mode, it kind of means maybe the accelerometer is broken in your phone. And then the Fukuda step test is what actually we're depicting here. So that's like Romberg, but you're having the patient march in place and close his or her eyes, and you have them keep marching. And so if one of the inner ears systems is weak, the good side tends to push them into, and they start to kind of spin actually and rotate. And then finally, this is a classic, the Dix Hallback Test is really specifically looking for benign positional vertigo. So these are those weird looking semicircular canals, really small structures that are your accelerometers. And we're lining up those canals in a certain way to test whether there's any, wouldn't you know it, loose crystals. That's what, really difficult to explain. But there are these crystals that rub on membranes to detect acceleration. So in that particular disorder, they get dislodged, and we can diagnose that specific disorder by tilting the patient back and turning their head towards the affected side. And when that's positive, boy, is it positive. And we kind of really can suspect it based on the history. When you ask the patient those questions, which I think are frankly more important than the examination, they'll tell you, yeah, I turn my head to the right, and then, man, the room is spinning for a matter of seconds. And you almost know that you'll do this test, and not in all, but you'll tilt them back. And in this image above, their eyes, they'll start to kind of, in a rotational way, start turning really rapidly, and the patient will experience their vertigo. So, having said all that, we'll do this full history and exam really aimed at understanding, is this, out of all of the different components in our body that kind of determine balance and our sensation of orientation in space, do we think it's really the inner ear? And if I'm suspecting that is the case, then we're in essence saying that it's that nerve, that vestibulo-cochlear nerve, the 8th cranial nerve, that innervates the balance inner ear and the hearing inner ear. So at that point, I think it's important to quantitatively assess it. And as you can imagine, as I've shown you with that diagram, I can look in with my otoscope, but I don't see past your eardrum. So there's really no way for me to quantitatively measure this. And that's why I work closely with our audiologist, Arielle Feiman, who I think will have her introduction now.
Thank you, Dr. Lerner. Yes, so now it's time for Arielle, because after examining the patient, Dr. Lerner may decide to involve some testing, and that's where Arielle comes in. And she's going to explain the different types of testing that you may require to help diagnose your problem. So Arielle graduated with her clinical doctorate in audiology from the Long Island Audiology Consortium. She has worked in private practice, serving pediatric through geriatric populations, performing a wide variety of audiological testing, including vestibular assessment, hearing assessment, and oral rehabilitation. Dr. Feiman came to Yale Hearing and Balance Center in October of 2020. I give her credit, in the middle of the pandemic, and works out of the Greenwich Voice Center performing hearing assessment and hearing aid services. She is currently a fellow of the American Academy of Audiology and holds a certificate of clinical competence in audiology. Arielle, welcome. Oh, you're muted.
I knew I was going to forget to do that.
There you go.
Here, let me just share this.
We hear you.
Good. Okay. So hi, thank you for the introduction. I'm here to talk a little bit about audiology's role in this whole process. I will say a lot of the time people come into my my room, my hearing booth, and they say, wait a second, I'm not here for my hearing, I'm here for dizziness. So, I mean, that I would say a good 80 to 90% of the time that happens. So Dr. Lerner actually did a really good job about going over the sort of anatomy that makes it a little more clear as to how your hearing and dizziness are connected. So, so I won't go too deep into this again, but you can see that the cochlea, which is that little swirl looking organ, is attached to the semicircular canals, which that is your vestibular system, all part of the inner ear. So sometimes small, even undetected changes in hearing can sort of point to what's going on. So a lot of times when people have these differences or a certain configuration of hearing losses, you know, they don't even actually know that it's there. And I just made a little chart to make a little bit of an example, because depending on, you know, what's going on with the hearing test is going to sort of push us in a different direction as to what it is or what it isn't, which of course is going to affect treatment and referrals and all of that. So when you look on the left, it says Meniere's disease, labyrinthitis, vestibular neuritis, and Bppv. These are just a couple of the things that can, of course, cause dizziness. So as you see in the symptoms columns, there's dizziness here for all of them. But when we're looking at a hearing test, you know, Meniere's disease and labyrinthitis, a lot of times people will present with somewhat of a hearing loss. Meniere's disease especially will be fluctuating. It can be low frequency. But you see with vestibular neuritis and Bppv, typically we're not seeing anything funky with the hearing test. So it just kind of highlights the importance of finding out what exactly your hearing thresholds are. I think also what Dr. Moore and Dr. Lerner made pretty clear is that unfortunately with dizziness, a lot of the time it is a process of elimination. So it's not like a lot of ailments where you go into a doctor's office and you say, oh, here are my symptoms. And the doctors might say, well, you know, let's draw some blood. We'll do 15 different tests on these 2 vials of blood and we'll figure out what's going on. Unfortunately, with dizziness, dizzy patients are really put through it. They have to go through a battery of tests a lot of the time to rule things in and rule things out. These are some of the most common vestibular tests. It's very, very rare that you would ever have to have all 6 of these. You know, people will usually always start with an audiogram or a hearing test. Electronystomography and video nystomography. This is the one that people Google and get a little freaked out. So we're going to go into all of this and kind of hopefully take away all of the scary things that people see on Google. Electro-Cochleography, vestibular evoked myogenic potential or a Vemp, rotational chair testing, and dynamic postureography. So I'll just go briefly into all of these. So, you know, if you guys are referred our way, you kind of know what you're getting yourself into a little bit. The audiogram is usually the first thing that will happen, sometimes even before you see the ENT. Sometimes the ENT will even say, you know what, let's get the hearing test first and go from there. So it's very simple. You sit in a booth and you respond to tonal and speech stimuli, and we try to figure out what your thresholds for hearing are. And like I said, this is pretty simple. It takes 15, maybe 20 minutes. So the ENG-VNG, like I had mentioned, is what people Google and get a little freaked out about. This test is a little bit more involved. It's about 60 minutes long. And what we're basically doing is monitoring eye movement, because your brain works in conjunction, you know, with your eyes and your balance system to keep you balanced. So it has to all work together. Unfortunately, because the balance system is encased in bone inside of your head, like Dr. Lerner says, we can't really see past your eardrum. So what we're having to do is use either electrodes, which is the ENG, or infrared goggles, which is the VNG, to monitor the eye movements during this test. There's 3 parts. First is ocular motor, second is positional testing, and third is caloric irrigation. As far as the ocular motor testing, it's pretty simple, pretty straightforward. This gentleman is having a VNG because he's got those goggles on, but the patient sits with their vision fixated forward. What you can't see, because this is obviously a picture, not a video, is that those lines on that TV screen that he's looking at are actually shifting. They're moving around. So we're measuring the patient's eye movements as they're following these targets. And this is going to rule in or out what's known as a central pathology. So it's not an issue with your actual vestibular or your balance organ itself. It's something more centrally related. The next part is positional testing. This is, again, pretty straightforward and pretty simple. As you can see, this woman is laying down, and it's a little hard to tell from the picture, but over the goggles is actually a cover. So we're monitoring her eye movements without her ability to fixate on anything. And then the audiologist will say, turn your head left, turn your head right, turn your body left, turn your body right. And we're just monitoring involuntary eye movement, which is also known as nystagmus. And this can help show us whether something is a central pathology or more of a peripheral issue with the actual balance organs themselves. The last part, and this is the part that is a little bit scary for people, but this is the part of the test that actually can make, it is meant to make you dizzy. It would actually, there'd be something wrong if this part of the test didn't make you dizzy, unfortunately. But it's very short-lived. It only lasts a minute or two. And typically all patients go about their life afterwards. You know, they're not, it doesn't trigger anything. You're not left handicapped. I've had patients, you know, hop off my table and just go right to work or, you know, do what they need to do. But it does cause a little dizziness. And some people will say, oh, this is exactly what it feels like when I get dizzy. Or some people will say, nope, it's nothing like that. But what we're doing is we're blowing cool air and warm air into the ears. And we're isolating each balance system one at a time in order to see how they perform on their own so we can see if it's symmetrical. And that's also what we're looking for here is symmetry between the two, because if one is totally overactive, the other one is going to be underactive to kind of try to make up for it in very simple terms, which can, of course, cause dizziness because they're not working as they should. So this is definitely testing the actual balance organs themselves to see how responsive they are. And like I said, it does cause dizziness, but it's very short-lived. The next test is called an ECOG, or an electrocochleography, and we've talked about Meniere's disease a little bit. And Dr. Lerner mentioned it's like an imbalance of fluid in the inner ear. It can cause dizziness, of course, and fluctuating hearing loss and ringing or tinnitus in the ears. So you really would only be referred for this if the ENT thought that this could be Meniere's disease. This is extremely easy. All you have to do is have two electrodes, which are like strong stickers on your forehead, and insert earphones inside of the ear, and you just listen to very loud clicking noises, which are very annoying, but if you can fall asleep through loud noises, you can feel free to take a nap for this one, because there's no participation, you just have to sit there, so it's nice and easy. The next one is a Vemp, which is very, very similar to an ECOG as far as setup. It's looking at a different part of the vestibular system. It's looking at what's called the utricle and the saccule to see if they are working normally. But it's the same premise. You've got electrode placements and you have the earphones playing loud sounds. The difference is the electrodes go in different places. So it could be under the eye, it could be on the neck, it could be on the sternum. And they're just measuring muscle responses from the vestibular system, or muscle reflexes evoked. This also, the rotational chair testing, again, these are not, the rotational chair testing it's usually ordered in conjunction with an ENG or a VNG, and it's very specific. It's if they're looking for a unilateral weakness, meaning one vestibular system being too weak, or a bilateral weakness, which is when both of the vestibular systems are just not working up to par, leaving you feeling kind of like you're walking on a dock. But the patient is put into a chamber, again, goggles monitoring the eyes, and it's dark in there. So that's the part that freaks people out. But the chair does rotate. And so what they're doing is monitoring your eye movements as the chair is rotating in different directions and in different speeds. So the last test I'll go over is called dynamic postureography. As you can see, the woman here is standing in like a half booth, and she's got a harness on so she doesn't fall. But what's happening is the platform underneath her feet is moving, and the visual field around her move is altered as well. And this just tries to sort of isolate your different systems that help contribute to your balance, to sort of see, okay, well, maybe it's a visual issue, or maybe it's more of a vestibular or somatosensory issue. So, you know, it can be fun. Again, it's usually ordered in conjunction with an ENG or a VNG. So it's if they're looking for something very specific, but yeah, I mean, that's basically, those are probably the most common audiological tests that are done. Again, it's very rare you'd have to go through all 6 of these things, but you know, just in case it comes down the pike for you, I just wanted people to kind of have an idea of what they're getting themselves into and the role that audiology can play. My contact information is up here. If anyone has any questions, please feel free to reach out. I'm available all the time.
Thank you. Thank you, Arielle. Fabulous. That's quite an interesting set of tests. Okay.
Yeah.
All right. So moving on, we now know that certain types of dizziness can be treated with physical therapy, or what we call vestibular therapy. And then you will be referred by your physician to come see one of us vestibular therapists. Basically, if movement changes your symptoms, then movement usually can be used to help treat your symptoms. So Marisha and I are both vestibular therapists here at Greenwich Hospital. We're both at the Long Ridge Medical Center. But we're part of a team of therapists at Greenwich Hospital specializing in the treatment of vestibular disorders and balance, including pediatrics. We also have a therapist that treats vestibular disorders in children. We have 3 different sites here at Greenwich Hospital. So I forgot to give you a little bit of information about myself. I'm a physical therapist, graduate of UConn many years ago. So I've been in the area practicing physical therapy for about 40 years, just a little while, but specializing in vestibular therapy the last 10 years. Marisha and I both attended a course at Emory University in Atlanta and received certification in clinical competence in vestibular rehab. Now, Marisha has earned her PT degree from Quinnipiac and her doctorate from Dominican College. She has also received a certification as an orthopedic specialist and teaches in a practical lab for PT students at Columbia University. She is our clinical manager for the Greenwich Hospital Physical Medicine Department at the Long Ridge Medical Center. She's going to talk to us about the types of dizziness that can be treated by vestibular therapy. Okay, Marisha.
There we go. Hello, everybody. Thank you, Sue, for the introduction. Just a little mention, Sue's been my mentor for vestibular rehab. I call her my guru. So she does amazing job. All right, let me see if I can share this. Okay. All right, so after seeing all the physicians, the primary care, the ENT, the cardiologist, the patient gets referred to PT because they've made sure that it is vestibular related symptoms. And what do we do as physical therapists when the patient comes in? You will see a little bit of a repeat of how we do our evaluation versus how the doctors also do our evaluation. So some of the questions kind of repeat themselves, some don't. Again, what is dizziness? Everybody explains their dizziness in a different way. Somebody says, I'm spinning. It's a whirling sensation. Somebody says, I'm giddy. Somebody says, I'm off balance. It feels like a fog in the head. I can't think clearly. I can't walk straight. There are several different explanations that a patient would give us as far as with like, explain your dizziness. So there are a few things with terminology. One is vertigo. Vertigo is a false sense of rotation where everything you feel like you're spinning or the world around you is spinning. Something is spinning. Oscillopsia is gaze stability. Everything is moving. like a boat. Imbalance is just unsteadiness. You can see an imbalance where a patient walks in and you feel like, oh my God, they're going to fall down. Disequilibrium is more subjective imbalance. A patient feels they are imbalanced, but if you see them walking, they're like, you are not imbalanced, but they feel they're imbalanced. And lightheadedness is usually a feeling of faintness. In our world, we feel like a vestibular problem or a diagnosis rarely causes like you're going to pass out. You're going to make you dizzy. It's going to make you throw up. It's going to make you crawl on the floor because you're dizzy. But rarely you're like, oh my God, I'm going to pass out. That's usually a cardiac problem. So when a patient comes in, we again take the history, neurological history, cardiovascular, orthopedic, psychological, surgery, current medications. We also know that a lot of medications interact with each other, causing dizziness, especially some psych meds that patient takes. So you have to make sure that these patients, you at least know about those, substance abuse, and then all the diagnostic tests that they've had in the past. We go through the symptoms of how often are they dizzy? Are they constantly dizzy? Does it come and go? Is it very positional? If so, what particular positions causing their dizziness? Do they have any auditory symptoms like any ringing, hearing loss, any pressure in the ears? Do they have any visual symptoms like they can't see clearly? They have double vision. They can't focus on stuff, stuff like that. So you go through the symptomatic approach to the evaluation. What is red flag for us? What is, if patients complain of any of this or multiple things of this, and we don't know, we have seen through the test and we're like, okay, this doesn't match what they're telling me, then we send them to the doctor. So declining hearing, a significant hearing loss, dysarthria, difficulty speaking, discoordination, where they can't coordinate, like they can't, the fingers and the arms and the hands, they don't move in a smooth way. Diplopia, decreased mentation, urinary incontinence. Some patients are just legitimately confused, and that could be due to other reasons. A significant loss of strength and weight in the past few weeks or months, decreased consciousness where they don't know where they are, dysfunction of the cranial nerves. Dr. Lerner and Dr. Moore went through the cranial nerve testing, and headaches. It depends. A lot of dizzy patients have headaches, but if they have significant headaches, which leads us to like a migrainous issue, then we will refer them back to the doctor. Physical examination. We check their neck range of motion. Cervical spine, which is this neck spine, can cause some of the dizziness that can be interpreted as a vestibular issue, but it's probably coming from the neck. It could be posture related, it could be arthritis related. So we do check their cervical spine range of motion. We check their muscle strength, make sure that's okay. We check their sensation, their proprioception, see if their joints are telling them where they're in space. We do the vertebral-basilar artery test, which makes sure that the blood supply to the brain is permanent and intact. We check the cerebellar function, which is cerebellum is the back part of the brain that actually controls a lot of our balance, but it's upper motor neuron is a brain related issue. So we check that if that's functioning right, and we check their reflexes. Then we do an ocular motor and a vestibular ocular exam. We check for nystagmus. It could be spontaneous where the patient's just looking at you. I will show you in a little bit what a nystagmus looks like. Or gaze evoke, like if you ask them to look at something, they will have the nystagmus. If you don't, they're fine. We'll check their VOR reflex. So VOR reflex, as Dr. Lerner went through, is the vestibular ocular reflex. It helps us focus our gaze. If I decide to turn my head, my eyes will just move with it, but it gives me the ability to focus on something while my head is moving. You should be able to use the vestibular reflex, and you should be able to cancel and not use the vestibular reflex if based on what your need is. We check the static and dynamic visual acuity of how great can you see, while how also great can you see when your head is moving in space. Head shaking nystagmus, and then hyperventilation induced nystagmus. Then we check for positional vertigo. This is the Bppv. We do the Dix Hallback Test, where we lay the patient down at the edge of the bed or holding your head to check for the otoconia, which is the crystals in your inner ears. As I tell my patients, you have rocks in your head. And they tell me all the time, my wife has been telling me this for last 20 years, but now I know. But yeah, so we check for that. We do the roll test because the Dix Hallback test checks for the posterior canal. As you see, we have 3 different canals, the anterior, the posterior, and the central. And every test checks for a different aspect of the canal to make sure that we're testing all 3 canals and making sure there are no loose crystals in those canals. Then we do postural control, balance, Romberg, tandem leg standing, single leg standing, dynamic balance. We do the Fukuda step test, the timed up and go, the dynamic gait index. Dynamic gait index is a very well-known and very well-used test where you walk in a straight line, turning your head, looking left to right, looking up and down, you walk over an object, you walk around an object to just make sure how your system functions when there are obstacles in the road. After all that, if we assume and if we come to a conclusion that the issue is vestibular related, we do something called the vestibular balance rehabilitation therapy. Its indication is we usually use it for Bppv, vestibular neuritis, labyrinthitis, a stable CNS lesion, anxiety, and it also can be used for migraine, head trauma, Meniere's disease. So what we do for a central issue is we cannot fix, if somebody has a stroke, I'm not going to be able to fix a stroke. But what we do is something called a habituation approach, where our balance is controlled by several different mechanisms in our body, vision, the cerebellar system, our joint receptors, our core strength. All those systems can somehow substitute for something that is missing. And so if you have a permanent vestibular damage or a upper motor neuron, like a central stroke-like issue, which is making you dizzy, we can train these other systems to substitute for it and habituate your body to function better and to feel less dizzy. So we do the grace stabilization exercises, the balance exercises, and habituation exercises, as I just mentioned. Before I'll show you a little bit. Bppv. Bppv is the most common diagnosis we come across. Benign is not malignant. Paraxismal is recurrent, sudden. Positional, it really depends on the position of your head. And vertigo is a sense of rotation. It is very, very common. And if this is the cause of your dizziness, it is one of the easiest things to fix rather than all the other causes of dizziness. It could be because of head trauma, car accident, an inner ear disease, genetic, sleeping positions. Unfortunately, there hasn't been a link to anything in particular that causes recurrence of Bppv. I've seen patients once and they never come back again. I've seen patients who come every 3 months because it keeps on happening again. But unfortunately, the research shows that nothing has been predisposing factor for Bppv. We do the Dix Hallback test where you lay the patient off the bed. By doing this, we're just putting the patient's head in a position to move that crystal in the ear to see if there is one. And if there is one, usually the Dix Hallback test moves into an Epley maneuver, which is you move the head in certain positions and you turn it in certain way. So if our inner ear canal is a C, it's closed on one end, it's open on the other end, and that's the open end is where the crystal fell into. So you move the head in certain ways so that the crystal moves and falls off back the open end. Unfortunately, every time the crystal moves, you feel a little dizzy. Fortunately, if you stay in that position and do not move within 30 seconds to 1 minute, your dizziness does calm down. We do it in a very safe way, in a huge bed, so you're safe, you're not going anywhere, but it's a very easy thing to fix. Brander off exercises are something else we can do where you lay on your right side, come on up, lay on your left side, come on up, do that 5 times each to help those crystals fall off the canal. After we've made sure the crystals have fallen off the canal, what happens is now you have an injured vestibular system on one end. It was affected by something. It's the injury is taken away, but still not functioning 100%. So as long as one ear is functioning less, you will feel the dizziness. And it's not at this point vertigo, but you just feel off. What patient call me, I feel off. That's when the VOR exercises, the gaze stabilization exercises, and the balance exercises come in to help you reset the system so that you can function better and you can go back to your normal life. So this is what we do for the Epley maneuver. Let's say it's your right side, you turn your head to the right, you lie down to the edge of the bed. So the crystal moves about 45 degrees down. And then you're going to stay right there. What we try to do is let the dizziness pass and then wait for 30 more seconds so that you make sure the crystal has stopped moving. And then you turn the head in the other direction, do the same thing, move the whole body so that your nose is towards the ground, and then you sit up. So sometimes this is a great maneuver, but sometimes if the crystal is not in the inner ear canal, it gets stuck to one of those membranes when I said the other side of the canal is closed. And then we have other maneuvers to whack that crystal off of the membrane and then get it out of the system. It's pretty interesting. It's torture for the patient, but it really 1 or 2 times and it does magic. I want to show you a couple of videos, so hold on 1 second, because this one first. Okay, so most of the time when I see patients and they tell me, how do you know I'm dizzy? And this is what I mean. This is what we see if you look the eyes. This is what we see when you feel the world is spinning and you feel dizzy. So most of the times we can see this through the naked eye, but sometimes if patients have had dizziness for a long period of time, they learn how to fixate this. So they are dizzy, but we don't see the response in their eyes. That's when we give them the Frenzel lenses, where you wear this big black goggles so that you can't see outside, but we can see your eyes. And once we do that, again, we see the same thing. I'm going to show you something else, right? Posterior canal, and we do the Epley. Now it has an ad. I hate ads. So that's the vision. Like that's what I wanted you to see, but that's what we see when you get the dizziness. Is the nystagmus. It's your eyes go like this. And some people, they feel their eyes bouncing. Some people don't, they just feel dizzy. But some people feel their eyes bouncing. Sometimes we can see it through, if the nystagmus is strong enough, we will see it through a closed, what is it called? We will see it through, even your eyes are closed, we can see the eyelid move. So that's something. And then I would also want you to show you a couple of more things and then I'm done. So these are your vestibular ocular, some of the exercises that we do, right? So this is a VOR1 where we're teaching your brain teaching your eyes how to focus while your head is moving.
This is VOR times.
Hold on, I just need to do one more thing. I think I need to share. Oh, the sound is shared. Okay.
1, the target is stable, but the patient's head is set in motion. Over time, it's good to increase the frequency of the head movement. And you can perform these in a variety of planes, horizontal, vertical, and then in a diagonal plane. And the patient is trying to maintain gaze stability during the exercise.
So that's VOR1. There's also something very interesting called a VOR2. And let's watch this and then I'll talk about
Exercise is VOR times 2, which means 2 things are in motion, both the subject's head and the card in converse directions. Perform this in a horizontal plane, vertical, and again in the diagonal plane, maintaining your gaze on the target of interest, making sure it stays in focus. Can increase the speed of head movement over time.
So these are some of the exercises that we do. These are just a couple of mine. But what happens is we start with something as plain as a blank paper with an A on top of it or a dot on top of it so that there's no background that is crazy. If you would have noticed, if you're dizzy sometimes or even if you're not, if you walk through a particular carpeted area, you're like, oh my God, this is crazy. It's making me dizzy. We use those backgrounds as a next challenge to train your eyes to focus on an object, even when your background is crazy and has a lot of input in it. The viewer too, where you see where you move your eye head in opposite direction. Most of my patients are like, we never do this. But you do. Think about what you're doing when you're driving or when you're sitting in your passenger seat. You're going in one direction. The other traffic is going the other direction. Now imagine reading a sign on the side of the road to know what street you are at. You have to focus on something that is moving in the other direction while your head is moving in one direction. So you need these reflexes for just basic stuff in life, which I know we don't do this all the time, but we use that as like a carryover effect to a lot of different things that we don't even realize that we do. So we use that as a lot, and also we use different speeds because not everything moves in one particular speed. So the exercise that the gentleman was showing is just to show you the technique, but then we use different speeds, different directions. We'll put you on a foam to do it. We'll make you toss a ball. It's a fun program, but it's really cool. And patients do get a lot better. Even if, as I said, even if they have a symptom or a diagnosis that causes some kind of permanent damage, we have other systems to substitute for it, and it does improve a lot of their functions. I'm gonna hand it over back to Sue. I'm gonna start sharing this screen.
So can you tell we enjoy what we do? We get very excited about our vestibular patients. So in summary, basically what we wanted to get across was there's a lot of reasons why you could be dizzy. It's a very common complaint, but remember, it's a symptom. It's a symptom of something going on. It's important to understand where that dizziness is coming from. Hopefully you got a little taste of the many different things we look at when you first go to your primary doctor, what he or she is looking at when you come in complaining of dizziness. Work with them, rule out anything really malicious. We want to make sure, if it's something really suspicious, you go to the emergency room, but you work out the really bad stuff. And then take care of that and then get referred to the appropriate specialist. And if it's suspicious for a vestibular problem or inner ear problem, you most likely will be sent to your ENT, otolaryngologist. To further differentiate what type of inner ear problem, get the appropriate testing from the audiologist, and then is it appropriate for physical therapy? And then you come to one of us to work on your balance or your vestibular reflexes. So that's basically it. Hopefully we haven't made you dizzy with all the information. There's a lot of information in there. We realize that, a lot to go through. But I want to thank our panel for their time and their efforts in preparing this and trying to help you guys sort out the mystery of your dizziness. So I'm looking at the questions in the Q&A. There, can you hear me now? Okay, sorry, I must have hit the wrong button. All right, technology. So what is the treatment if there are loose crystals in the semicircular canals? That's what we love to do the most. We test you first to find out which canal and which maneuver would be best. Either we'll do the Dix Hallback, the roll test, the side lying, and then we'll do a maneuver to fix the crystal. Please, 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 please do not go on YouTube and do the somersault, the half somersault, or whatever they call it. I can't tell you, Marisha will tell you, there have been people that have tried on YouTube, they come in so sick, and it actually has become, it's more difficult to resolve the issue because we don't know what you did with that crystal, but it went somewhere and it's very hard to get back out of there. I've had some of them convert to what we call the horizontal canal, and the horizontal canal is more difficult to treat. So please call your specialist and come see a specialist and let us take care of it, and don't do the YouTube. Okay, next question. Hopefully that answers your question. If you are not having an episode, is the doctor able to do any tests or provide a diagnosis? If you're not having, I'm not sure I understand that question. If you're not having an episode of dizziness, is the doctor able to do any? Yeah, maybe Dr. Lerner, can you address that?
Yeah, absolutely. So yeah, I think the history, which was really that conversation with your provider about the symptoms, can give us a lot of information. So, we learned a lot about this during the start of the pandemic, where we had to do so much telehealth. And if we really talk through what's happening, how you're experiencing it, we can really come up with a pretty good idea of what the likely possibilities are. And then, if the physical exam elicits the dizziness, yes, I think maybe you gather that for certain conditions, seeing it actually happen is helpful, but the history, I think, is still paramount in understanding the likely diagnosis.
Okay, another question for you. How can allergies influence dizziness?
How can allergies? So I guess it comes down to maybe what, if someone, if a patient came through with that question, really would have to spend some time talking about dizziness again. What do you mean? So I think just having allergic inflammation, sinusitis or rhinitis can cause a sense of congestion, and there's advertisements where the head looks like a balloon. I mean, maybe that is what the patient is meaning when they say dizziness. But we talk about the vestibular nerve, the balance nerve, and we theorize that in certain cases that nerve is insulted by some environmental factor. Usually we think about viral insults, but we also think about, with a lot of different types of conditions in medicine, we think about possibly an allergic insult. But I think most of the cases are probably the like rhinitis, nasal congestion, where people are dizzy that way, I think.
Thank you. Okay, maybe Dr. Moore, can dehydration cause dizziness? I think you kind of addressed that, but you want to
Really, yeah, dehydration can be a big issue. Your body's basically a pump full of fluid. And if the pump is on low fluid, then a lot of times you're not getting enough oxygen carrying capacity and other proper stimuli in your systems. So whether the dehydration is because of not enough water or fluids in your diet, or you're dehydrated because of blood loss from a bleed or another cause of a low blood count or an anemia, then certainly low volume is a critical issue, and one of the basic things we test for in blood testing when someone comes in with that complaint.
Thank you. Okay, does the crystal dissolve? Well, from what I understand, what we do is we relocate the crystal. So the crystal comes from the lining of the utricle, which is the little sac where all the canals hook up. It dislodges, gets in the canal, we relocate it. So I love to use the analogy when I was a kid. I played with that little labyrinth thing. You get the little rolling ball around the little maze and get it back to the hole. That's what we're trying to do. We're trying to get it around the maze, get it back into the hole, and get it to stay there. So my belief is that it reabsorbs into the utricle on the wall. Correct me if I'm wrong, if anybody else wants to clarify that, but that's my thinking is it doesn't actually go away. And if it doesn't reattach or it doesn't get reabsorbed, it could reoccur. Anybody else want to chime in? Okay. There's a comment, and I will share, doctors are clueless in how to treat dizziness. So this is exactly where this presentation came from, because I hear the frustration. You've been to a number of clinicians that you feel don't know how to treat your dizziness. You just have to look to find someone who you can talk to, who will listen to you and try and understand your symptoms and refer you to the right specialist. And that's, like I said, part of the reason why we came up with this presentation is because people went from doctor to doctor to doctor, specialist to specialist, to try and figure out what's wrong. Maybe Dr. Moore, you have any comments to that?
Well, certainly, I think we've made some headway that it's a very complicated issue, and there are many, many pieces of information that have to be taken into account and carefully gone through. Dizziness complaints often take multiple visits, sometimes to multiple places, in order to get all the information we need to make the kind of definitive diagnosis that a patient is most satisfied with. one of the reasons I used the patient example that I used is because she had actually had so much testing for other issues recently that a lot of that had been done as background information, and it made her movement through the whole process a little more quick than it would have been. But oftentimes when we're testing a patient, we have to get one answer before we can know which test comes next. And so the patient feels like it's a never-ending funnel of doctoring. But the fact is that we have to take things stepwise because it can lead in so many different directions based on different answers we learn. But I feel for the patient who is having trouble with that. And I can understand that it can be very, very frustrating, and you have to just keep chopping away at your doc and make sure that they're hearing what you're saying.
Excellent. Thank you. Thank you. All right. To clarify, I guess, Dr. Lerner, should one be evaluated if they are not currently experiencing any symptoms? Can I get an ENT appointment if not having an episode of dizziness?
Well, if you have no, I don't know if I understand the question completely, but if you don't suffer from dizziness, then you don't need an appointment. But if you have episodes that are just, you don't need to be having the episode in the office to see your doctor. I think we talked about, some cases are relating to the inner ear. So you may find very quickly in the ENT office that I think it's related to blood pressure or something else. But we'll look, if you suffer from this problem at home, can absolutely explore that and come up with a differential diagnosis list and get the ball rolling.
Yeah. Oh, yeah. I think that's what they're talking about. If it's that episodic dizziness, you have bouts of dizziness, but you may not necessarily be dizzy at that moment. Sure. Come in. Did you go to your primary doctor first? And yes, if you want to explore with the ENT and see is it an episodic problem, and you don't have to be dizzy when. You can still do the audiology exam. You can still do the physical exam. We'll go through the history. So yes. How do you treat the disembarkment syndrome? I call it says disembarkment syndrome, but it's maldebarkment. Dr. Lerner, if you want to go first, then I'll go.
Sure. So, maldebarkment syndrome is, it's just, I know the person who's writing the question knows what they mean, but basically it's often occurs after having been on a boat, let's say, for a period of time, and the patient is now off the boat, but still has that sensation of motion. And, I would say that most cases of maldebarkment, in my experience, do resolve spontaneously over time, but I think that actually is you tell me, so I think that's maybe a prime candidate for vestibular rehabilitation.
Well, and that's where Marisha and I will probably do some of the habituation exercises. We're trying to get them used to movement again, but in graduated steps. I actually had somebody come in with what I consider maldebarkment after a really vicious roller coaster ride, and feeling that sensation of like, whoa, what's and persistent. So it's and there's some that last and are a little bit more challenging. Try and break it up and try and get them used to movement again. You have anything to add, Marish? No? Okay. I've already had vertigo and treatment and PT, still having lightheaded off and on. Where should I go now? I didn't have all the hearing tests done. Can anxiety cause it? Dr. Moore, you want to start?
Certainly. You should definitely go back to your primary care doc, who can continue to take a look at the distinct difference between vertigo and lightheadedness. People can have more than one problem going on at the same time. And although your vertigo may have existed and been treated, you may be still left with another problem that needs to be reassessed. There was a second part to the question.
I didn't have all the hearing tests done. Can anxiety cause it?
Anxiety, okay. So anxiety is a cause of dizziness. Sometimes people have very physical symptoms when they are overly anxious, and we can do some testing for that, but we still want to make sure there's no physical problem going on that is there as well. Sometimes when a patient is having a combination of anxiety and dizziness or lightheadedness, and I'm trying to figure out if there's more than one component, I might give them something short acting for anxiety to see if when they use a medication, does everything completely resolve? And I'll do that in a careful test environment with them in low doses. And then if they're still left with symptoms, we will then go on to try to find more information. But this is a fairly large cause of dizziness, can be either multifactorial with anxiety being one component or based on a psychiatric problem as well.
Thank you. Okay, question. Should the Epley maneuver be done on a regular basis as a preventative therapy? No. No, Epley is done for a specific purpose to relocate the crystals. If you want to do any kind of preventative therapy for you really can't prevent Bppv. It just, it happens. It's spontaneous, it's paroxysmal, it just happens. So there's no real way to prevent it except don't hit your head. No. I mean, I would do Brandt-Darif as preventative, but that would be for other reasons, not for crystals. You don't prevent crystals from happening. What about the buildup of fluid in the brain, hydrocephalus? Dr. Moore?
So normal pressure hydrocephalus is a disorder that is treatable by placing a shunt that takes fluid from circulating around the brain and putting it in a place where it doesn't cause as much problem. The classic triad of symptoms is dizziness, urinary incontinence, and I'm blanking on the third one. But it is typically a certain specific set of symptoms. You can sometimes have 2 and not 3, but it is something that your doctor can consider testing you for. And some of the imaging testing that we do is one of the reasons we do it is to rule out this fluid around the brain.
Okay, great, thank you. And then there's a comment, my experience is that the symptoms can be very subtle. Dizziness symptoms can be very subtle and anxiety can be a response to the sensation. So you may experience as primarily anxiety when really anxiety is a response to the dizziness. History is very important. Agreed. Agreed. Yeah, any more comments on that, Dr. Moore? And no? No?
I think it's an excellent observation that the patient has made, that that's true. And we have to be careful and listen very carefully to ferret out what comes first. But you know, the other thing to remember that if a patient is having anxiety, whether it's based on dizziness or some other thing, they may have sort of a low-level anxiety state all the time. And so we want to make sure that we don't overlook things that are cues that require treatment, whether it's talk therapy or meeting with the doctor more regularly or cleaning up their medications to make sure that we're not evoking any of this through the pharmacy as well.
Okay, terrific. So there's a thank you in the Q&A. Thank you to everybody. So I want to say my personal thank you to the panel. You guys are great. Appreciate it. Enjoy working with you. Anybody else have any other comments or anything?
Thank you again for inviting me. Thank you for all our attendees. I hope that we were able to give you some useful information and reach out to any of us if we can be of help. Thanks so much.
Thank you. Well said. Thank you. Good night, everyone. Have a good night.